I'm pleased to welcome you to UVic and to this event, and I will now turn it over to Andre, who I believe is our first speaker.
Lisa. So today's event is entitled Displaying Health Data, Cases, Techniques, Solutions. This colloquium series will discuss information visualization and statistical graphing featured in health research. The series will invite to share ideas, lessons, and insights from real-world projects, and instead of listing the promises and challenges of data science, we will talk about cases, technique, and solutions. What worked, what didn't work, and why it didn't work, or did. So here's the overall schedule for this 3 days. The colloquium will have 3 themes, one for each day. The first day will be focused on health data in general. The second day, where Basha and Shannon will be talking about substance use. It's a thematic day. And finally, we will conclude with a discussion of pipelines and dashboards on Friday. So today's talk is entitled Visualizing... Ooh, I think this is the wrong talk. I'm ahead of myself. That's the second talk in the series. So today's talk is entitled, Transactional Data of Island Health, How Patients Vote with Their Feet. And we'll try to explain what we mean by patients voting with their feet. But first, a little story behind this talk. Exactly 4 years ago, and ILA, at that time the Center on Aging, held a colloquium series on methods and application for aging research. And that was the event where Ken and I met each other. And it was a very meaningful event for me. It was my first semester on campus, and it was sort of set the stage for everything that was to follow. You can catch the videos from that colloquium after this slide, and after that link, and also there will be all the slides and presentations will be distributed on my GitHub page, and I'll show you the link later. So the last image from that colloquium 4 years ago was this. It was about the dialects of data expression. The idea encoded in this graph is as follows. We have some digital fact about the world that we can represent in varieties of ways. In this case, we see 7 ways or 8 ways in which we can represent. We can structure or show the data tabularly, where this is the most common way how we can represent data. We can create an algebraic expression that would encode the essence of that tabular display, but do it with some error or with distortion. We can we can express the same data as a collection of numerical indices that are associated with a particular statistical model, or describe it schematically. But most of the time, we really like the graphical form because it's the most intuitive to our eyes. And so the image on the top right retells the parable of 6 blind men who touched an elephant. They touched it from different sides, and they described the elephant differently, although that was the same underlying reality. So that's the metaphor that I think connects both colloquium series 4 years ago and this colloquium series. When we see graphs in this and subsequent presentations, I would like us to think that all other forms of expression are sitting there underneath. And the role of the data scientist is to create dialects that would allow people to translate among those expressions and finding the expression that speaks to them, that helps them understand the underlying data better. So today, we're focusing on explaining what do we mean when we say how do patients vote with their feet. Specifically, we will demonstrate 2 solutions to 2 problems. Problem number 1 is, how do you represent a journey of a single patient? How do you represent how the patient traversed the space of health continuum, how he or she accessed health services throughout their lives, and what can we tell about it. The solution to that is a clinical context coding scheme. This is the scheme that Ken and I have been working for the last 3 years, and represents our stellar achievement to date. The second problem we will tackle has to do with how do we summarize a collective experience, right? Let's say that we can represent a single person's trajectory through the space of healthcare system. How do we then make it compare groups to each other? It's a different visualization challenge, and we'll demonstrate how we use a sequence of alluvia or Sankey plots to do that. So with this, I'm handing over to Ken, where we will walk through the case study for a single person. So how do we handle problem of displaying data for a single person?
Have I done this correctly?
Yes.
Okay. So then what do you want me to do?
I would like you to describe, and this is back and forth, how to tackle the problem of representing a single person's trajectory through the space of healthcare.
Okay. Well, this is really a very sobering situation here. I'm surrounded by an unusually high concentration of people that I know will be perfectly willing to disagree with me and tell me that I'm completely wrong. So it'll be nerve-wracking but very refreshing. So in advance, thanks. Appreciate everybody for coming and joining us today. So the only thing that I really care about is, I just obsessed with one thing, with in-person overtime, which in healthcare we call the patient journey. Well, actually, the patient journey is not encompassed by healthcare. The patient journey is just the person's journey, and then they have sort of side trips through the health service system. But those side trips always unfold over time. And we can just try to keep our life from getting too complicated by focusing in on short episodic illnesses that we treat and hopefully cure, and then the person goes on their way. But generally that doesn't work because the person as a whole, there's a different process happening, which is called being born, and then a variety of stuff happens, and then it all comes to an end. And the health service system sort of weaves through that in a very complex sort of way, which we would like to it weaves through that, and there's this very complex interaction of the person over time in the health service system and its operation, but it is not a random relationship. So we would like to understand what are the non-random aspects of it, and can we use our understanding of what the non-random aspects of that interaction are to help us improve quality. So that's sort of the process that I gave to Andre and said, here, I'll get the data for you. You figure out how to do the analysis. And then he turned to his friend Will and said, Will, can you help me on this? So anyway, let me just show you a picture. Okay, so this is a de-identified picture in the sense that it's a composite representation of more than one person. So this is not, I go into obsessive detail later on about what I mean by de-identify, which I won't do right now, but it is, according to my own very unusually high and exacting standards. But let's just make believe that we were going to take a look. This is a picture running along the x-axis. We have time, and we've got 2,190 days, and then running along the y-axis, we've got clusters of programs, sort of groups of programs that do more or less the same thing for people. And so if we started running along from the left to the right, we see, well, okay, we've got a sobering assessment center encounter, and then the person is in intake for addictions, and then you see a bunch of those green lines there running across the page. Those are all, of course, emergency department encounters, but also running along the page. You see a band of blue, which is sobering assessment center encounters. And you can't quite see it down there, but there's detox encounters, and there's 27 of them distributed over the course of time. So this is what, Basha, to our conversation before, this is an act of desperation, right? Because once a person goes to detox 27 times, you don't have any illusions that that person is actually going to stop using drugs. But you know you got to do something. So this is a within-person over time depiction of a single patient journey. But you can also see that these events here over time are probable. Some of them are correlated with one another, and there's some kind of a pattern here. It's not just a random It's not just a person randomly moving through the 1,700 services that collectively constitute Island Health, that there's things that go together. Or in other words, you could say that there's a naturally occurring service delivery model here that is reflected by the sequence of services that this person accesses over time. So if this is me moving through the service system as I go to this service and this service and this service and this service, and then back to this service, that's me saying, this is my integrated service delivery model. It may not show up in the books of Island Health as an integrated service. Island Health has its own administrative view of how programs are clustered together, but my version of what are the cluster of services that collectively constitute the stuff that I need from the health service system is my feet moving through the health service system saying, this is my version of what should be an integrated service delivery model. So that's kind of an allusion to what we meant by voting with our feet. So let's carry on. Did I do something wrong besides ignore time? Okay. All right. So now let's dig into a little bit to what the problem is and why do we come up with this thing called the clinical context coding scheme. So if I want to get all the a record of all the person's encounters with the health service system, I get a long Excel spreadsheet that says Mr. Jones was admitted on such and such a date to House 3. And then a few days later, Mr. Jones was admitted to House 2, or then they were in A wing, or then they were admitted to a program called East. And then they were in Holly, then they were in Grove, and then they were in 4C, and then they were in Outreach. Outreach for what? Well, who knows? It's just called Outreach. Then they were involved in a program called Intake. Intake for what? You don't know. So if you get a record of all the patients' encounters with the health service system, you can get a very, very long listing of the stuff that's completely indecipherable. So typically what happens is people say, well, look, I don't know what these 1,700 programs are, but I know what RJH4C is. That's an acute care unit. And I know what RJHED is. That's an ED unit, right? So I'm just going to look at the acute care encounters, and I'm just going to look at the ED encounters and the acute care encounters, and I'm going to use that as a proxy for patient engagement with the entire system as a whole, and just forget about the rest of the stuff because what I have is, out of 1,700 programs, I've got 1,615 quirky and idiosyncratic names for programs that somebody took the service system over time and carved it up into pieces in an idiosyncratic way and called them programs for administrative reasons, then came up with an opaque nomenclature for the programs. And I can't analyze this encounter data. What am I supposed to do with it? And they did it differently in Vancouver Coastal, so we can't compare the data, so don't even bother. Let's just talk about ED. We're just going to talk about the ED, and we'll talk about acute care, just like we've always done. So now let's so what we did was we created a system. We created a system that would enable us to provide visibility and clarity on what are these 1,700 programs that collectively constitute Island Health. And other people have tried to do that before. And what they did was they just took the 1,700 programs and they added one more column to the spreadsheet and they came up with new names for the old program. So you took an old idiosyncratic nomenclature and replaced it with a new idiosyncratic nomenclature. But still the fact of the matter is that most people in the universe don't know what 1,650 of those programs are. So we came up with a different approach. We attached 6 pieces. We attach 6 pieces of information to every single one of those. So here's your spreadsheet with a long list of programs. Now we've got 6 more columns attached to it, which talks about the intensity of the 2 variables that talk about the intensity of the service, because an admission to an intensive care unit is a different entity than an admission to a regular med-surg acute care unit, or an admission to a case management service where each case manager has 50 clients is different from admission to an assertive community treatment program where each person has 10 clients. So we have 2 variables that are concerned with intensity. If you know that a person was admitted to a program but you don't know what EAST is, you would probably want to know, well, what's the focus of the program? MHS, mental health and substance use addictions. Okay, it's pretty high level, but it's better than EAST. And what's the service type? Detox. Now I'm starting to understand. And what's the location? Detox facility. And what's the population? Adults, some adolescents, and older adults. Okay, well, okay, now I know what. So if we attach these 6 pieces of data to like a whole bunch of locations whose names we don't understand, but if you got those 6 pieces of information attached, you go, okay, I know what this is. It's a detox facility. Or you got something like this, but it doesn't say detox, it says post-withdrawal stabilization. You don't need to know what Holly and Grove are. You don't care what Holly and Grove are, but what you need to know is that they're post-withdrawal stabilization units, because now what was opaque becomes transparent. So let me sort of illustrate the problem a little bit. And this is, so when you reach into the back end of Cerner Millennium, our electronic health record, and you get all the encounters out of that, you have 1,700 locations. And then you bring the 1,700 locations into the data warehouse, and you see, well, what does the data look like when it comes out of the back end of Cerner? So here we've got 1, 2, 3, 4, 5. We've got 7 detox locations. So they come out of Cerner with a facility name attached. So you've got mental health and addiction service, North Island Community Care. Then you've got another detox called MHSU Residential Detox. Then you've got MHSU Residential Stabilization Supportive Recovery. Building name Lily House. Well, that doesn't help you. Then the data warehouse added some more stuff to it. So sometimes they call it inpatient residential. Why? Because it was physically located in an inpatient unit. Well, who cares whether it's in an inpatient unit or whether it's located in a building in the community? What you really want to know is I don't want to know that Johnny is in an inpatient residential place. I want to know that Johnny is in detox. That gets to the heart of the matter. So what you've got is a quirky, sort of a quasi-indecipherable, uninterpretable terminology that's used to describe the programs coming out of Cerner, and then we add some more labels to it in the data warehouse that just add inconsistency to it. So we decide, okay, we're going to put 6 pieces of metadata on every location. We're going to really, really try hard to apply those consistently so that we can render transparent the individual chapters of the patient's journey, and so that you know what every step of the way is and that you don't ignore all of the community-based stuff. So that's what we did. Now, the other thing that was, I'm just going to jump ahead and I'll just take you to the punchline. So if you take these 6 pieces of metadata and you attach it to the 1,700 plus locations, or 3,400, depending on how you count, but I'll be generous and just say 1,700. If you attach those 6 pieces of metadata and you code them according to the intensity type, and you code them according to the level of severity or risk addressed by the program, and you code them by the clinical focus, and this is really, really high level, right? Because we don't want to make more complicated what is already complicated. We want to condense things down. So we'll say, okay, this is a program that has something to do with it's a neurological program, or this has something to do with your GI system, or this has something to do with your heart and lungs. It's very high level, but it's better than not knowing anything about the program. Or, well, what kind of service did you provide? Well, we provided some kind of a primary service, who knows, or a pharmacy consultation, or a morgue encounter. So this is a very high-level coding of service type. And where's the service take place? It happens in a facility, it happens in your home, it happens on the street, in the ED, in the lab, or medical imaging. And what age does the service target? Children and youth, adults, mixed, whatever. So you take these 6 pieces of metadata, you take these 6 categories, and you code every single one of those 1,700 locations, and then ask yourself, how many different combinations of values do you get on those 6 pieces of information that you've now layered onto the locations? And the answer is 153. So what this means is you now have 153 entities that are relatively homogeneous at a high level with respect to the intensity of the service delivered, where the service is delivered, what the problem is that it targets, and what service is provided. Very high level, right? But you started out with 1,700 locations, which is unanalyzable, and you got it down to 153, which is now a palette that you can use to paint a picture of the person's journey and have some hope of understanding. So you may ask yourself the question, this person must this person's diagnosis is probably something like obsessive-compulsive disorder superimposed on some other deeper and darker, personality disorder. We won't go there. Why bother doing this in the first place? So let me show you why you bother doing this in the first. I guess I should remind myself this is being recorded. Okay. Let's take a look at a picture up here. Okay, so the Center for Disease Control decided that, actually, it was the public health officer for the province of British Columbia decided that overdoses was a problem, correct, and that we should look into it, correct, and that we wanted to identify opportunities for intervening and engaging with people who are at risk for taking an overdose. So we needed to paint a picture of the way the person interacted with the service system. But they held themselves accountable to only working with data that they could get from all of the health authorities. And what could they get from all the health authorities, and what is interpretable and meaningful from all the health authorities? ED and acute care. Okay. Well, let's take Mr. Jones that we have reason to believe is at significant risk for taking an overdose. And let's put on our ED and acute care goggle lenses and take a look at Mr. Jones. And what do we see? Between 2010 and 2012, we see one encounter, ED med-surg. So he showed up in the emergency department. Then it looks like he went quiet for 4 years. And then we've got a couple of ED med-surg encounters there, and then we've got another ED med-surg encounter. Now he's in acute care med-surg, so he's not well for 18 days, and then he's out for probably a day or two, and he's back in acute care med-surg for 11 days. So that's this person's journey. So you look at this, and you say, well, gee, now that I'm building my prediction model for people who are at risk for taking an overdose, is this person at risk for taking an overdose? I'm not worrying about this person. And you say, okay, let's get the other 1,973 locations into view using that system that we just showed you. And then we find out, well, gee whiz, between 2010 and 2012, we had 44 encounters with mental health and substance use programs. Then he shows up in the ED, which we got above. Then he's in crisis response walk-in. And then, which, by the way, does not involve a physician delivering care, so it's never going to show up in the MSP billing data because a lot of services, particularly in mental health and substance use, are not delivered or directed by physicians, so they don't show up in anybody's records except the encounter data. Now he's in crisis response walk-in, and then he's got 55 more encounters over a 4-year period with various mental health and substance use programs. Now he's in detox. Detox, right? Detox beds are scarce, so if he's in detox, he probably has a significant addiction to something and is at risk as a consequence of withdrawal. Crisis response walk-in, addictions ambulatory, et cetera, et cetera, et cetera. So you take a look at this, and it reminds me of the psychiatrist, the chief psychiatrist in the alcohol inpatient unit at the VA hospital in San Francisco, where I interned many years ago. Or I remember in rounds one morning was talking about a patient that he just interviewed the day before, and he says, and when I sat there in the room with him, I thought I could hear the rustle of angel feathers. That's just how he spoke. He spoke in epigrams. He says, because I knew that this person was not going to be around for long. Right? You look at that person down there and you figure that that person is in a world of trouble. And that something, aside from those 2 med-surg encounters, other bad things going to be happening to that person. And that's what you get when you get the full continuum of secondary and tertiary services into view, and you don't just go, with what data are conveniently or readily available. So now you take another, take another look at this. So now we get to the supreme problem, which I will not be able to solve, but I've given it to Andre and the bad company that he keeps, and they'll figure this one out. So this is an individual patient journey, okay? It's a composite patient journey. But the only reason that I was even able to create a composite patient journey was because I got a bunch of patient journeys that all looked the same, and then I sort of mixed them and matched them. But if they all look the same, then it means that this is not a quirky or idiosyncratic version. This is a type. This is a type. This is not a one-off sort of a scenario. Or this is one patient story. You go to the English literature people. The English literature people say, well, there's 1 million novels, but there's only 5 plots. And then another English literature person will come along and say, you're an idiot. That's wrong. There's 11 plots. And somebody else says, no, wrong. But I researched this. The largest number of plots that I came up with anywhere is 22. There are 22 stories. That's it. So even if we have 170,000 people in the mental health and substance use encounter, cohort, which is what we got. If you have 170,000 people, you got 170,000 journeys, but you have at the most 22 longitudinal types. So how you use every statistical and data visualization tool you can get your hands on to deal with this very, very complex body of information, because you could see even from that visualization there, you got at least two classes of events here. You've got high contrast, low frequency events. Like an acute care admission doesn't happen a lot, but every time it happens, it's really, really significant. Then you've got low contrast, high frequency events like all of those ED encounters, but you maybe should be treating quantitatively. You want to take all these different kinds of data types. Some stuff's, maybe you treat it ordinally or however, or binary and stuff. Some stuff's quantitative. And you say, turn it into 22 longitudinal types, and then segment the types so that we can predict the later stages from the earlier stages, or show that you've got people who are clustered together and then it fans out at a certain point in time, and why does it go in one direction for some and not in the others? That's the problem that I that Andre volunteered to solve for me. So we created this cohort. In Island Health, it's anybody who ever had an encounter with any of those 444 programs that collectively constitute mental health and substance use, or they ever had an acute care admission with an MHSU discharge diagnosis, or they ever had an MHSU procedure performed, and that gave us 170,000 people. And it gave us 170,000 people and a really monumentally challenging methodological challenge, which I will hand off to Andre.
It was the problem of how to represent a single person. Now we're moving how to represent multiple individuals. So I will walk you through this handout that I've also placed on your desks here and there. If you don't have it, there's more copies at the front. And it looks colorful, but it requires a little bit of effort to actually go through and identify how we use the visualization to comment on the story of the group experience. So let me go through. This is the back side of this handout, and also note that the PDF would be available of this high-resolution PDF of this handout will be available at the URL listed below. Also, that URL will contain the lecture slides from this and further talks so that you can follow. This also would be a good place to review if you want to ask a question during the talk. Okay, so one of those 6 pieces of metadata that Ken talked about had to do with service location. So there's 14 different service locations. And in order just to simplify our life a little bit, we looked at this and we said, you know what? Everything that happens in the healthcare system could be classified into 3 bins. Either it was happen in hospital, or it happened in location, in community, or it happened somewhere else. And there was another exception, and that's the staple, which I will talk a little later. But keep this in mind. There's hospital, there's community, and there's everything else. So taking that a little higher order grouping, we would like to focus on the following graph. So this is called the alluvia graph or Sankey plot. And the alluvia, it implies something being carried to a river carrying mud to a different location. So you can think of this. This is 2 qualitative variable, 2 categorical variables. One categorical variable called service group. This is what I just showed you, a larger grouping. And the second categorical variable is called service location. This is one of those 6 pieces of metadata that Ken talked about. So the height of the bars of the axis represents the total number of encounters that group had. So this stands for all of the encounters that this cohort generated. right? So we're dealing more than 4 million encounters, 4 million times that there was a digital ping saying a person engaged the services of this program, right? So the tallness is, the height is how many encounters there were. The individual boxes represent the groups, so we can see that there was 1,279,595 encounters in the hospital. The color in this case shows us all those encounters that related to mental health and substance use topic. Also, interesting thing to notice from this graph is this disproportionate category called staple. And what is it? Well, we're going to zoom in into that category and look a little closer, although you can still see it uncolored on the previous graph. So all this huge collection of, or disproportionate number of encounters came just from 3 locations: hospital, Island Health Lab, and medical imaging. So anytime that anything happens to you, you're probably going to get, sent to lab or done something imaging. So they're very low differentiating bins. If you know that you had an encounter with this service, we probably cannot tell much more. Everybody has it, that kind of thing. Okay, so the strategy we would like to employ is we'd like to focus on that pink ribbon or blue ribbon, purple ribbon, but yeah, I keep changing. But in order to do that, let's make sure that nothing is hiding in the other stuff. So let me just quickly show you what's in the other stuff, and then we'll zoom in into that violet, blue ribbon. So this counts the number of events in the service group staple. Only 3 services are responsible for a disproportionate number of events. It dwarfs any other classes by comparison. So just because it's a problem to visualize the height, right, to visualize how engagement differ from group to group, we just cannot see because it's there and it destroys our graph. So we want to get rid of it so we can focus on things that are important. So we know what kind of categories are there, so we move on. And now we focus on this small section of other. So you can see how small relative to the overall proportion it is. It's right here, right? So again, just to see what's in it, so we don't have to squint too much. We see that it's a different lab, a morgue, pharmacy, telehealth. So again, nothing particularly interesting in here. We just want to get rid of it just to know that we've accounted for it so we can move on to more interesting stuff. And that's that violet ribbon from the total encounters that we want to focus on. So a darker color indicates MHSU services related to addictions, while a lighter color are more general MHSU services. Notice that most MHSU events occur in community-based services. So if you pay attention to the sizes of the boxes on the left axis, so again, this is group, this is categorical variables, we see that most of the MHSU events happen in the community. So that reinforces our suspicion that if we don't have community data, if you don't have secondary and tertiary data, if you're looking just at acute and ED, you're missing a whole lot. And it's particularly important when you're talking about MHSU mental health and substance use populations, because you don't see what's happening. So now let's zoom in even further, because what we would like to, that's the wrong direction. Oh, right. So we take a subset. Community is our main focus. But just to be thorough, we want to look at this small location hospital just to understand what kind of services of MHSU-related thing we have in the hospital. So this is the following graph. And you see that the scale of it changes so that it's not always proportionate to the previous image, just so that we can scale it better. Okay, so this is counts of MHSU-related services that took place in a hospital setting. So we got hospital ED, that's the service location that we got, and hospital. And you can see the classes ID, the IDs of the individual classes of services that are the minimum unit or the smallest unit of our clinical context coding scheme. Things like dedicated psychiatric emergency setting, MHCU specialist consultation, or in various types of acute care. Now, again, this is not our particular interest. We know this happened in a hospital, and we will zoom in if we need. But today, we would like to talk about the back side of of the handout that focuses on the community services. So just to remind you, remember this right here. So we start with all the encounters that this cohort generated, and we're focusing on the violet ribbon. Those are MHSU-related encounters. When we do that, we got this. Now we remove this hospital and focus just on the community, and that's what we have here. So if you notice, there's 4 columns on this handout. Those 4 columns is the same graph repeated 4 times. The only difference is the color. So let's make sure that we see the axes again, because the axes are slightly different from the previous graph. The left side contains service location, that one of the 6 pieces of metadata that we created, while the right column contains the actual class, the smallest unit in the CCCS, right? This is the smallest unit that would be exposed to the researcher. The researcher would not know anything else but that thing. That is supposed to be a descriptive label that unites services that are homogeneous with respect to the kind of service they provide, okay? And individual lines, okay, yeah, so individual lines right here, they represent the service classes. And the prefix encapsulated in square brackets relates to the class ID, so it's a little bit easier to pick it up from the scheme. And if you want to filter an audit or something, it's much easier to know the code. And the suffix at the end of it represents the numeric value of all the encounters that you encounter, because sometimes you get the difference in scales. It's hard to see and compare graphically, so you want to know the overall the number. So each panel colors the identical breakdown of service locations into service classes according to 4 dimensions of the clinical context coding scheme. So in this case, we color it by service location 2. So if you notice, every band right here is of the same color. Every box on the right is of the same color, and it shows you how that category, how that location, service location, splits up into different classes and where it's happening, right? Or where how the service classes capture that. So, right. In the same way, we zoom in. If we switch to a different view, to a different column, this counts number of MHSU-related services that took place in a community setting. Each panel, oh, that's the same. So just for your information, the same image represented 4 exact same times. The same letters and numbers are represented there. The only thing that changes is the color. That allows us to get this high-level view of what's happening and how things split up into 2 categorical variables plus the 3rd categorical variable, color. And I'm out of time, so let me end with this. So again, PDF handout is available at the website. So in conclusion, we demonstrated solutions how to solve 2 problems. One, how to represent a person journey as single. We did it with the help of CCCS, because otherwise you would have too many Y lines. It would be 1,700 different lines on that one-person view. It's untenable. We need smaller. This is what CCCS did. Second, we solved the problem how to represent a cohort experience. We took all of those 170,000 individuals and told the story of that group, what that group was responsible for in terms of burden on the health system. I'm not particularly happy with those visualizations because it has some flaws. For instance, it's very hard to read, right, because they're spaces. Well, that's part of the problem that we're dealing with. If you need to represent 70 unique items on the single sheet of paper just to state what they are, how are you going to do it so that you preserve at least some statistical property? This offers, the Alluvia plot offers some solution, but by no means it's a good solution or the appropriate solution. It's just a solution that we were able to implement. There were some other that were even worse. So if you can think of something else, please let me know. So now, what can we do with that? Well, let me give you this idea for your imagination. Well, how would you capture the similarity of those two individual trajectories? So remember that individual trajectory plot with a bunch of lines happening. How would you even capture and express two or three people having the same? Is it going to be just a constellation of those dots that define what a person, what that group, similar trajectories? How would you even represent, not mathematically, but just graphically? Second, how would you compare a target group to the reference group? Let's say that we have the general cohort that had any sorts of engagement with MHSU services. That's our reference group. How can then we take and express two experiences of a cohort? Let's say we focus another cohort on those people who only been to detox. Only those people who had a detox encounter, that's our cohort. How do they compare to the general population? I don't think the Alluvia graph would work because it's hard for the group comparison, right? We need to invent a different representation so that those comparisons would be meaningful. How many individuals would be on those groups in the reference and in the comparison group? It will depend. The solution to the graphical statistical graphic that compares those groups would be heavily influenced by those things and as many other factors. So I'm out of time. I'm sorry. Please email questions about this talk to aging@uvic.ca. Once again, the poster is. A handout is available at this URL. We're looking forward to your questions in live and in person and via email. So thank you. Ken? Why don't you come? I feel lonely here now.
Okay.
And Harjot, you will be taking the questions online? Okay. We left them speechless.
Okay.
So I love the idea of attaching the meta characteristics, or I forget what phrase you used, creating.
Oh, right. I'm sorry. Very important announcement. If you want to ask a question, please there's a button in front of your mic.
Hello?
And yes, you got it. So there's a light that lights up at the tip. That's how you know it's live.
Perfect. Yeah, I love the idea of attaching these meta characteristics to each encounter and then grouping them or figuring out how many combinations you have. I have found that researching substance use can be particularly tricky because there's not really a standard rehab center, for example, or a standard outpatient provider. The services within each differ dramatically, for example. So I'm going to steal this approach. But the question I have for you is, how did you go about determining which of those characteristics to apply? What your 6 meta characteristics? Was it based on your research question? Was it based on the frequency of the characteristics across the population? How did you pick those 6, like location, et cetera?
Pain and suffering. Honest to God. So what I did was I got the location build from Cerner, which is just a list of 1,700. It's a list of 1,700 units with a few other, like what's the building they're located in, and what organization are they affiliated with. Because I've been in Island Health for close to 24 years now, and because I've been through the location build in Cerner Millennium at least 3 or 4 or 5 times, I have a pretty good idea of what a large portion of those programs are, and if I don't know what they are, I have a decent idea how to figure out what they are. So I literally started on program number 1, and I asked myself, is program number 1 the same as number 2 or not? And if they're the same, in what sense are they the same? If they're kind of the same, in what sense are they the same? In what sense are they not the same? And then over the course, so over the course of time, what I did was I evolved the categories, going through that list of 1,700 locations. Then after I evolved the categories, then I had to go through the categories again and see if I got the same categories. And I had to keep doing it until the system stabilized, and I was able to get through it twice without it changing. So that's how I did it. I literally just bootstrapped it right out of the data. So like one of the challenges that I encountered initially was service intensity, because it became apparent to me that we have regular med-surg acute care unit, we have an intensive care, and that those are different levels of intensity, but that we don't scale intensity for acute care units the same way that we would scale intensity for community, for case management. So I'm not going to put all 1,700 programs on the same service intensity scale. So then what am I going to do? So as Andre came along and said, well, group the programs, create categories of programs that would be homogeneous with respect to the way that you would rate them according to their service intensity. And that's how we ended up with the service intensity classes. And then all the programs within a service intensity class would then be rated according to their intensity. So that's almost sort of like, that's like a meta to the meta data. So, but it was literally plowing through it until the system stabilized.
It was like doing factor analysis by hand without any numbers, and going through it twice, a couple of times. So I was watching from afar and not very courageous to step in. So,
and we're about to do that with all the DSM diagnoses as well, because and there are various people who want to do things with it. You go, okay, well, let's call things anxiety disorders. Well, let's call things conduct disorder until you find out that there's diagnoses that are a combination of sort of mood and conduct. And then when you've got a diagnosis that contains 2 things, then you go, well, let's force it into this or let's force it into that, but it's never going to work. And then as soon as somebody else comes along, they want to do something with the diagnosis, they don't like the way you did it. So what we're doing is we're dimensionalizing. I mean, we'll work loosely with the chapter headings in DSM, but we will dimensionalize it with as few dimensions as we can get away with, so that you can set parameters on those dimensions to create cohorts that are sort of diagnostically similar, but that you could cluster them differently depending on what your question is. Like, so if I just want all the psychotic illness, I don't care whether it's bipolar disorder, manic with psychotic feature, or schizophrenia, I just want all the psychotic illnesses, or I just want all the mood disorders except for the people with the psychotic, et cetera, et cetera. Okay. Yes.
Pressing the button again. Yeah.
Very nice work. It's really nice to see this progressing. Ken, how much closer are you to landing on the 22 archetypes, and what kind of work is next
we are
in
not
that journey?
Close.
Because that's the difficult part.
We are not close, and I believe that we're gonna have to do some basic partitioning. We're working on doing a basic partitioning of all of those different locations according to sort of the psychometric properties of, like we know that like ED encounters, for the people that we're concerned with, we think that we can probably treat sort of quantitatively, and we can generate some sort of a rate variable if we can decide what the time frame will be. Something like detox would be that because there's a lot of people who have no detox encounters, then there's some people who have at least 1 detox encounter, but there's a difference between 1 or 2 detox encounters and 27 detox encounters. So we have to figure out how to treat. If we treat each cluster of locations as sort of a measure of some property of a person, then we have to figure out how handle it from a psychometric standpoint. And then I suspect what we're going to do is to just point some truly dust bowl empirical, like trajectory mining sort of algorithms at the data, not because just to get a feeling for how the algorithms interact with the data and what does it spit out, and is there anything useful here, and really just to sort of advance our understanding on how to do it. It's going to take several iterations.
I wanted to address that as well. So you can think of statistical models that we can run against this. So, for instance, right, it would be very computationally intensive to model the constellation of those things, because if this is a measurement model, right, we would assume that there can be a measurement at every time point. So when there is no measurement, it's a missing data. So how to wrap your statistical models around that restriction is quite tricky. So one of the ways to simplify this problem would be, for instance, to flatten it with respect to time. So instead of seeing this temporal series of dots, you just get a total number of dots in that dimension, and then you can a much more wieldy vector to model that removes all the longitudinal information, but it's one simplification. Right. So there's some tricks and.
So that would be some kind of a cluster analytic kind of a thing that for which we collapsed across time and just looked at which programs form a naturally occurring group for which people routinely interact with the same cluster of services.
I'm sorry, I don't see the clock anywhere in the web. Oh, right there, of course.
Got 2 minutes. Victor.
Yes, I have 2 questions, related questions. I think that the CCS tool is very useful, and I wonder, have you tried to explore the use in clinical settings? Because for a particular client, to have all this information in one piece will be very informative. And together with that, would not be something that will be useful for you, your analysis, to validate how they look alike or not different clients, having feedback from the clinicians?
Well, I've certainly envisioned this as a very useful tool, because, I mean, the standard thing to do when you're about to see Mr. Jones, whom you've never seen before, is to do a quote-unquote ADT summary. So you just tell the computer, show me all the encounters that this person has had. But if you get an ADT summary for a person who has literally hundreds of, when you talk about the birth to death electronic health record and you say, well, show me all the encounters for this person, you're going to get a really, 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 really long list of encounters. And again, you've got the nomenclature problem, because it's going to because 95% of those encounters are not going to make any sense to you, so you're going to defocus, and you'll just pick out the ED, the acute care, the ED, the acute care, and that's all you're going to get. Whereas that, for better or for worse, is the sum total of this person's encounter with the entire healthcare system, and we've fairly brutally clustered programs together so that instead of having 1,700, right, 1,700 rows there, you got a maximum of 153 for somebody who has hit absolutely everything, but nobody does. And that, to me, like, I look at that picture there, right, that leaps out and beats me over the head, and gives me a message. Like, for one thing, it tells me, like, this person is not going to stop drinking, and this person has, chronic recurring health problems, and is crisis prone, and is going to just keep, interacting with something in the service system on more or less a daily basis. So we can do it the easy way or the hard way, but we are going to see this person every day. So what's the best way to do it? And so I think that this would be very useful to provide people with a very quick condensed view of what's going on with a person. The challenge is to get this kind of a visualization in front of the provider just in time for them to deliver the service. And for that, it means that you have to then get it, built into the electronic health record.
Can you not do this as a pilot?
Pardon?
Can you do this as a pilot for a group of providers, clinicians?
We absolutely could.
And
I believe it would be a good thing, and then we could get all the feedback from the providers on is this useful? What can make it more useful? It would also be very, very useful to engage the clients in this as well, because I look at this and I get one, and I graft my meaning or my story onto it. I could be totally wrong. I would like to get the people who own the story to tell me what the story is. Yes.
Welcome back. It's 2:10 on the island. If you hear me, clap once. If you hear me, clap twice. If you hear me, clap 3 times. Thank you. Welcome back. It's 2:10 on the island, and we're launching our second talk of today, entitled Visualizing Logistic Regression with the Coloring Book Technique. And as soon as I find my remote control, we'll be on. There it is. Okay. So, a subtitle of this is a study in ggplot, and I fancy myself an artist, so you know how they do a study in apples, or in the different colors and pastels. So this is a study in ggplot. I'm trying to see what kind of mileage I can get out of a particular geom, a particular ggplot system. So, little previous work. This is not the first time I talk about this technique. It was originally developed by Will Beasley and myself for a Groningen harmonization exercise of IALSA in an integrative analysis of longitudinal study of aging in University of Groningen in 2016. And you can examine the slides if you'd like, but we don't have time for that. I also have, I've presented on this quite recently. One is at the Matrix Institute Colloquium series, and another during a webinar series by Power of Population Data Science webinar series by Population Data BC. So those references are available, and I encourage you to look for them to get more details and more application of this technique. So, today, here's our schedule for today. We would like to, my talk will be basically in 2 sections. First, I will describe and demonstrate the technique, the graphing technique employed. And then the second part, I would like to offer some highlights on the workflow, what it took to create those, and some comments and advice with respect to implementation of this visualization. This most recently, the reason I'm saying there is a repository also linked after this that demonstrated this technique in a fully reproducible framework. So you can download a repository and just walk through the steps and examine the scripts that they take care of it. The data for this graphing exercise came from a hackathon event hosted by the International Population Data Linkage conference in 2018. The synthesized data contained linked socioeconomic and mortality data representing of Canadian population. There was a total of a little more over than 4 million records. Each record is a person from all the provinces, but we really don't need that much data for this demonstration, so I just subsampled the data to contain a little less than 4,000 cases and only 9 variables. So that's the data we'll be looking at, and you can see roughly what kind of variables I kept. So, and we'll go over them in greater detail. So, without further ado, let's jump straight in directly into the model. So, as I mentioned in the opening slide to the series, we can represent data in various ways. We can represent it graphically, but we also can represent it through algebraic equation. This is what I'm most comfortable with. I'm a quantitative psychologist by background, so I like formulas. They soothe me. So let's talk about a relationship between data. In this case, we would like to model a relationship between a single variable. In this case, the DV, the dependent variable, is mortality, yes or no. So is the person dead in 10 years, in 5 years, in X number of years or not? It's a fictional data, so it doesn't really matter how long that is, whether it's dead in X years or not. And as I jump through and explain the variables used in this model, I'll be pointing the marginal distribution in this variable so you can kind of guess what's in it. But don't read too much into it. This is just to get you an idea of the distribution behind that variable. So we can formalize the relationship between the mortality and a set of predictors using a logistic regression equation, which models the dependent variable as the function of intercept and the intercept. There's a link function, a log linear transformation that allows you to express the parameters in slightly more intuitive manner. Again, don't worry about the equations. We're gonna go past it because we're gonna be visualizing the results of that longitudinal logistic regression. So this is our dependent variable, dead in X years. Our PR stands for province, so you can see the distribution of the sample where people came from, and we're going to be focusing on 4 most populous provinces: Quebec, Ontario, Alberta, and British Columbia. There are others were just not sampled well enough in this data set. Age group from 19 to 90 in a 5-year grouping, and again, you see the distribution that it's supposed to be representative of the Canadian population, with probably some caveats when it comes to early age. Female, again, I like to represent the sex variable in a less ambiguous naming, so it's a yes or no, true or false variable, whether the subject is female or not. Marital status, the distribution shows only 5 categories, but here, and it's not very visible on the screen right now, but a PDF of this slide will provide greater detail. There's actually 6, 1, 2, 3, 4, 5, no, 5 again. There's a transformation that I've used in order to minimize the number of grouping. This is better viewed in the education case. So there's only 3 resulting levels of education. That's why education 3. But there were more than 9. There was like 11 different levels of education, and they were very, very specific. So I didn't want to deal with 14 or 11 levels of a predictor. So I collapsed them into 3 because that's what really matters. Is it less than high school, or more than high school? That, at least that, as a researcher, I justified it because my fictional research hypothesis didn't involve greater granularity of education. Poor health indicator, there was 2 items. One is measuring activities of daily living in 2 different ways. So if any of those items reported as yes or often, I marked them as disabled. So, and finally, first official language of the respondent. We have English only, French only, both English and French, and neither English nor French. So that's our data. At least that's the model. So let's look at the data that we used to visualize. So what happened is, so we got the data, the training data set. We estimate the logistic regression that I've specified at the bottom. We get the parameters associated with those slopes, individual slopes, and then we predict fictional cases using those parameters. So we say, okay, let's say that you're a male living in Ontario. You are 24 years of age. You are not married, and you have high school education and okay language and fine, not poor health, and your first language is English. There's some cases that match that definition exactly. So what I did, I created all possible combinations of predictors the levels of predictors, and I've generated those predicted values using these all possible levels, plus the coefficients that were estimated given a training data set. So every point in this graph represents a person, a fictionalized person, but nevertheless, and I jittered the values just a little bit just so you can view it a little bit better. The x-axis is the age group. Oh, specifically, it's the floor of the age of a 5-year category. And the y-axis is the probability that R is dead in X years. And you have to do a little bit of transformation to get it back to the away from the log linear on a natural scale. And so that allows us to talk about probabilities. Otherwise, we would have to graph the log odds, which is also an option, and you can see how it's done in the Groningen exercise that I've linked before. So the interpretation is the higher the dot, the higher the chance to be alive in X years. So the higher, the better. Those people on the top, they tend to survive. They tend to do better in terms of health. And it's not surprising that the older the people get, the less likely they survive next X years. Very predictable and very reasonable expectation. When we visualize probability because it's just a little bit more intuitive to interpret. So, moving on. Now, as you notice, so what we did, we created a facet that binned subjects according to their province. Right? So if before it we had sort of muddled view, everybody was there. We wanted to separate it into individual provinces so it's a little bit easier to see. In a Groningen exercises, there was, for instance, a different longitudinal studies. Or you can think of another grouping factor that would make sense into separating so that you can compare it head to head. So that's our facet. And next what we did, we created 4 identical copies of the same row. So notice that the rows, the dots, individual dots, are different from row to row. But they're identical, from column to column, because they represent different provinces. But they are identical from row to row. And that's for a reason, because we want to color them differently, and hence the name coloring book. It's the same black and white, but we color it different, and the color reveals different information about the graph. So, notice that first official language is not displayed in this graph. Why? Well, because we don't expect it to be, we don't expect to have the exact number of predictors that is convenient to work with. Maybe we'll have 20 predictors, but maybe 10 of them will be not because we're interested in them, knowing what kind of effect they hide, but we just want to control for them. Right? So it makes sense to have a long regression that controls for many things and then zeroes in on a handful of predictors, and this is what we want to evaluate. So the FOL, forced official language, is not depicted here to represent that there will be other predictors that are not going to be portrayed, and that's okay because we have a focus. Okay, so the book is ready for coloring. So to help us get the next point, let's ask ourselves a question. How do we encode an informed expectation into this graph? Right? The graphs are valuable because they have the capacity to surprise us. Because when we're surprised by what we're seeing, we say, look, hold on a second. How do I explain that? If we were to see graphs with a lot of people, a lot of dots right here on this left bottom corner, we would be surprised because it's counterintuitive to our logic. No, it's the people who are older that's supposed to have poor health or have a poor level of survival. So the question, what should the reference group be for each predictor? In other words, what do we expect based on the existing research? And we'll use the color green to represent a reference group. So in the first case, in the first row, where we're representing an effect of being female on your outcome. will place it, will, let's say, make male as a reference group. In the second, when we compare marital, we would like to make single as a reference group. Well, just because this is what our intuition, our research intuition tells us, that people who are not married, they tend to do a little less in terms of health, and those who are married, they tend to do a little bit better. So we'll choose single as a reference group, and then we'll use the deviations from that status as an informed expectation what to expect in terms of health. And you can see why it makes sense to take high school as a reference group, because there's one group above it and one group below it. So that's the general idea. And again, poor health, we'll use the people as healthy as the reference group. So you see where the reference group fits in the overall results. Let's keep going. Compared to reference group, what levels of predictors are expected to increase the mortality risk? Well, when it comes to female, not being female is associated with certain health risks. This is what we know from the literature, right? Females tend to be healthier. So it would make sense if we encode males as a group having moderately increased streak. This is what we expect, right? According to the previous state of research, or at least according to our intuition. So if we see, let's focus on the top row, if we see that the green dots tend to be higher than the orange dots, we know that our expectation is confirmed. The graph does not surprise us. Marital versus, so we said that we wanted single to be our reference group, and we say that widowed will represent a moderately increased risk, because we know that being separated and divorced poses greater risk to your health than being widowed. That's, again, something that we infer from the existing research. So we'll look at the juxtaposition of those two values, and we see that being single, the green dots tend to be higher than the yellow dots, right? No surprise here. We encoded an expectation into the graphical display, and we only alarmed only when that expectation is violated. So that's the utility of encoding this expectation into the graph. So next question, compared to reference group, what levels of predictors are expected to decrease the mortality risk? Once again, we're out of categories in the first row, so we have to let it go. But in the marital status, we expect that being married is associated with greater, better health. So by comparing the widowed to the married, we see that, yes, it's actually, there is a substantial increase in probability of surviving the next year. What levels of predictors are expected to affect mortality risk drastically, substantially increased risk? Well, in our case, being separated and divorced, really bad, and a poor health. And again, this was an item that asked to indicate respondents whether they had difficulty with daily living activities. So naturally, we would expect that the red dots would be substantially lower than any other dots. And you can particularly see it in the bottom row, where the red dots dominate the bottom of that bivariate distribution, really in a more drastic way than, let's say, the third one. We don't specify the size of the effect of that expectation. We'll still have to evaluate the statistical properties of the model to do that and get the effect size. I'm not against that, not at all. But however, this allows you to have a more intuitive understanding of what the effects of the combination of predictors on the outcome. And it also creates a way to communicate your findings in a more straightforward way, not through a logistic regression table that sometimes some people find them offensive. I don't. I like them, but to each its own. So notice that, well, first of all, we don't have a substantially decreased risk in here. And that's because, well, sometimes maybe we don't. Maybe we don't want to, we want to show that there is no variable in this collection that is associated with substantially decreased risk. And that's fine, too. There's a way to encode the absence of that expectation or as well, and that's just remaining them blank. Notice that if we plot all colors at once, this may be not as informative as we may think. It may require too much tweaking to make useful. What do I mean by that? Well, depending on the number of dots that you want to represent, right? You can tweak the alpha parameter that controls the transparency of each dot, which makes it maybe a little bit easier to see when there's a cloud of overlapping dots. But if you have, let's say, more than 1,000 dots, and those dots are big, you just get, there's nothing you can see. So sometimes it can be useful, but if you want to isolate the effect and show how the specific a predictor affects the results of the outcome of your regression, maybe this technique is your go. Notice also that not all predictors are worth visualizing. This is what I mentioned before. Some are just there to control. Right, so the system that I'm demonstrating, you have to go into scripts to see how that is being implemented. Allows you to sort of change or select the variables that you want to visualize, and disregard those that you just want to control. So we can either keep it the focus on here, or we can exclude the female a predictor and add the first official language, right? So we accomplish it by this, by doing this. So this is where the time in the presentation where we would open the computers and start reproducing it. However, there is a video, this webinar that I recorded recently goes into greater detail of this section. So I will not show it here for considerations of time. But if you access it after the link, you can watch the video on that. However, I would like to make some comments about the workflow. I know we don't have much time, and it's hard to make commentary on workflow when you don't examine code. And as data scientists, this is what all of us should be doing, is looking at the code. So let me offer some highlights. So first of all, I'm very proud of this paraphrase. It's attributed to Plato. It's supposed to be carved out on the entrance to the Plato's Academy. It said, "Let no one ignorant of geometry enter." Right? Because Platonism was this interesting hybrid between philosophy, religion, and so you spend your time contemplating the perfect ideas, right? That's supposed to give you revelation. So if you couldn't understand how a triangle is different from a circle, and what is the difference of what are the features of the geometric forms, you couldn't contemplate the universe. So hence, don't enter. So I paraphrase: let no one ignorant of literate programming enter. Right? The famous phrase by Donald Knuth from his literate programming: I believe that the time is ripe for significantly better documentation of programs, and that we can best achieve this by considering programs to be work of literature. Hence my title, Literate Programming. Let us change our traditional attitude to the construction of programs. Instead of imagining that our main task is to instruct a computer what to do, let us concentrate rather on explaining to human beings what we want a computer to do. And that really sums up my philosophy of coding, right? This is, even though I'm telling computer what to do, I'm writing to people about what I tell the computer to do. Otherwise, we cannot reproduce, we cannot learn. So, some highlights. When you download this, clone this repo, or if you agile programmer fork this repo, you will notice that the structure of this repository has a lot of structural similarities to a repository by Will Beasley, who's in the audience today, called R Analysis Skeleton. He's been developing this repository for the last 8 years, 10 years. And it represents a starting point for pretty much any analysis in R. So normally what you would do, you would go to that repository, clone it, get the latest update, and Will has been very active and updates it almost every week. And this is my normal routine. I go clone that repository, and then I tweak it a little bit here and there to match the purposes of my particular project. So you would notice there are structural similarities between our analysis skeleton repository on the left and my repository on the right. So they're the same folders called data public, data unshared. This is where we separate data from the scripts. There's the same folder called manipulation. There's the same folder utility, but then I add folders like libs and sandbox because I have a very specific and consistent use for those subfolders, and it's integral to my workflow. So even though I like what Will is doing, but that's too generic for me. I want more customization. So that's my highlight number one. Notice the structure of my repository, and check out Will's R analysis skeleton. Oh, and a comment at the bottom. The reason why you might want to do it is because if you're a data scientist, you're probably involved in many projects. And it's hard to imagine the new structure for every time you do a project. So you want to keep that structure as similar as possible so you can switch between projects at the lowest expense of your cognitive load. A second highlight, I would like to draw your attention to the idea of layers of isolation. We want to separate the ideas of analysis and presentation. And that idea is very powerful, very powerfully encoded in this formula. R plus RMD equal HTML. What do I mean by that? Well, in most of the reports that I do, and I operate in R universe, not Python universe, but let's not go there. I operate in R universe. So in our universe, there's two types of files in a reproducible workflow that makes it easy. One is R resolution. This is where the scripts are contained. This is where we store analysis. And RMD that stores our comments about the presentation. So you can think about R as what really happens. This is what computer is told to do. And RMD is what you tell, how you choose to tell. You may not tell everything. You may display only sections of what actually happened and store other less interesting stuff in the R script. So expanding on that, let's look at the application of this principle. So here I am in my repository. I'm focusing on the folder reports. This is where I store analytical products coming from this repository, and I typically have a single subfolder for each analysis. In this case, I'm zooming into the graphing phase only, and that's the report that you would want to open and reproduce if you want to try to learn these graphical forms yourself. It's fully reproducible. The data is added to that repository. So here, notice that I have two files of the same name, graphing phase only. And also notice that it's the same name as the name of my subdirectory. And again, this is a very conscious choice, so we can better keep track of it. And even though I know that it's graphing phase only and it's stored in the same folder, but when you will be posting that report, it will store only the name of the file. So I tend to repeat the name of the file as well. And there's another reason that I will get back later. So these the two files, R and RMD of the same name, they produce an HTML. And you see the HTML right here. And normally, well, it would produce the HTML of the same name as R and RMD. And this is how they connect, right? Well, not how they connect, but this is how they connect conceptually. It will produce the HTML of the same name, but I manually renamed it just so that when I reproduce it again, I don't lose the draft edit. So that's hence 1 and 2, and I go for the largest number to get the latest draft. So it's just one of the applications of doing that. Another idea is you can use the same R file, you can connect the same R file to two different RMD files to produce two different HTMLs. Why is it important? Well, imagine that you want to create, you do one thing, you do this script called EDA, Exploratory Data Analysis, right? But some sections of that EDA are too technical, right? You don't want to expose your CEO to those details, but you also don't want to create a brand new script, because that complicates the management. The more scripts you have, the more management it will require, your repository will require. So you want to have a same RMD, as in this case, we have eda.r, and that's our R file. And then we have two different RMD files. One, just EDA1, that does the general exploratory data analysis for all the data. And then I created an exact copy of the same RMD file, but added a little section that filtered the data to contain only first-generation immigrants. And without any other changes, I recreate the same report using having an entirely different subset of data. Sometimes you don't want to create a whole new file. Sometimes you just want to control the changes easier. However, I find it much more powerful when when you can supply both R and RMD together. Anyway, moving on, may come back to this a little later. Third concept that I wanted to comment on, my third workflow highlight, is two essential means of production. Feel a little revolutionary, so let's talk about means of production. There's two functions how you can turn R scripts into HTML. One is called R Markdown Render. Another called is knitter stitch. Now, why do we want to care about that? Well, R Markdown Render requires you to have an RMD file. It would not work otherwise. You have to get R and have to get RMD, and then you can produce something. Well, the feature of this is that you can export not just HTML, but you can create PDFs, you can create ebooks, you can create various other output formats. Well, those are the main, not ebooks, PDF, Word document, MD, and so forth. But the catch is you got to have the RMD file that provides the instructions how the annotations will be done. Knitter stitch is different. It requires only R. It doesn't require any additional file to render an HTML, but you cannot do anything else. It's only going to produce HTML. The cool thing about this stitch is that it prints everything. It's a very generic function, and it just prints everything that it sees in R file. So it's very useful if you don't necessarily want to publish that report to a wide audience, but you want to have it for yourself, so you don't have to log in and recreate the environment and walk through the R script yourself and seeing in the console how the code reacts to what output is produced by what code. You have the verbatim record of the code and the response to that code, the output of that code. And as you can see here, I have a R and RMD for this technique demonstration report that I've written. And in my RMD file, I provide specific examples, like I do a specific subsection and provide additional annotation to my report. But at the same time, I produced, as you see in the stitched output folder, I produce this stitched document that stores everything. So when I go ahead and edit my report that faces the public, I can examine the detailed output and know what to cut or how I can subset it, what do I need to, what is the full record of my analysis. So in conclusions, we talked about the graphing technique, how we actually create and what the graph means. We talked about the modeling form and the graphical form, and I explained what the coloring book technique is, mapping different colors onto a blank canvas. And then I offered you 4 workflow highlights. Let no one of literate programming enter. So if you're not ready to read the scripts, well, you got to reconsider your career in data science, because this is what you'll be doing. You got to learn how to read scripts, and you need to write scripts expecting that other humans will read it. Insight number 2, highlight number 2, go check out our analysis skeleton repository by Will Beasley. Phenomenal work for great repository to start your analytical projects, and you may want to deviate from that form, but that gives you a very solid form to start with. Highlight number 3, layers of isolation, R and RMD. That's the major formula of data science. R and RMD produce the output, HTML, PDF, whatnot. And keep in mind 2 essential means of production, stitch and markdown render. They will cover 80% of your needs as you start in working in R universe, and specifically R Markdown and R Knitter and Markdown. Please check my repository, NCOV IPDLN 2018 Hackathon. It contains a fully reproducible example. And I'll be happy to get your questions in by email. So please feel free to email me or leave me a message or clone my repo and contact me. There's little less that I enjoy more than discussing data science solution with complete strangers on the web. So give me a call. And that was it. Thank you very much for your time. Don't forget to press the button.
I liked how you explained the skeleton. It's better than any time I've ever explained it. If you can write something up about it. When you're doing the logistic regression graphs, did you have ideas that you thought would work really well, but were a bust and hurt clarity or something? Or were there any things that you found that it would have helped the experts, but would have made it harder for a new person to get into the graph and understand? And if so, do you have kind of general advice? In Portland, not in Portland, in Groningen solution, we toyed around with plotting the lines of log odds, and I found that it was confusing people a little bit. Like the statistician would prefer the lines of a log odds instead of the individual person display. But people who are not necessarily on the first name basis with logistic regression found it confusing, and it was easier for them just to go for the person level data. Another comment. So distinction between that was I think. After feedback, I decided to stick with this because it was more intuitive. And another you might find this superficial, but choosing the color palette, so that it's sensitive to color blindness, so that it's doesn't crowd. There's many things that go into the choice of color. So that was I guess would be my advice. Don't overlook selection of color. Because, notice that red is more dangerous than green, which is, nice. So it's always nice to build in not just expectations, but also meaning behind the choice of your palette. So, but again,
very interesting and very well presented. I really like it. I enjoy it. One question, Andre. Even in your presentation, you were playing very nicely, moving back and forth from different slides to show different categories in colors and combining. My question is it possible with ggplot to do some interaction, to do kind of these effects, to select different categories and color different ones? Or you need another tools like Shiny, for example?
So, excellent question. I think Will would be more qualified to answer it, and I'm looking forward to your comment.
I know that there are efforts to, there's a GG animation. There's some packages that help you like do a basic JavaScript integration. So like there's the package that allows you to do a hover pop-up, right? So that when you zone in, when you hover your mouse on a dot, it shows you the value behind that dot. But those have limited applications, and by the time that you wrangle them, it's easier to go to things like Shiny, for example. So right now, I don't know of a easy. There are many animations available for ggplot, but right now, to my knowledge, they're more in an experimental stage than a more standard employment. But Will, I'm sure you will have a comment on that.
Well, I liked how you brought up GG animation, which in a sense takes a bunch of static graphs and makes it in a moving GIF. And so you could just put it on a web page and cycle through it. The graph would cycle through itself as opposed to requiring the person to click on it. And I think that draws people in sometimes. Regarding the JavaScript stuff, some have gone for this to try to replace ggplot in a dynamic format. Some have worked, some have sputtered. A nice kind of easy entry into it is in the Plotly package. And if you guys care, I'll tell you about it later. But Plotly package, it takes a ggplot object and tries to make it makes it a JavaScript object. So you could take this, pass it through this function, and it does some kind of hovering for itself. Like you can hover over that point, and it may say the X is this, the Y is this, and it's high school. Mm-hmm. And so for just one line of code, you get an initial jump into the JavaScript display. And that would work for some purposes. It may not be enough for other purposes that you'd have to go to a deeper way of specifying the JavaScript. But I recommend that as just an entry level and see what you can get. It's a good bang for the buck.
And I have to, I realize now that it's being recorded, so I have to make this proof myself. It's changing. The world of ggplot is evolving so fast that if you're not reading news on it for a couple of months, you may miss something. So I may very well be ignorant of a really cool thing that does exactly what you have in mind, but I just didn't have to happen to discover it yet. So hope that now I'm safe. Yes, please.
I think I misunderstood the question when I was referring to interaction. I thought it's referring to interactions between some of the variables that you use there. So that it's a little bit of an upstream work that you solve it in the logistic regression. And I could easily see an interaction between marital status and gender, mm-hmm. because according to the literature, you might find that for females, it's not that meaningful. Like being married, it doesn't necessarily increase the expectation, keeps it the same. Mm-hmm. So that would be interesting to look through interactions. And I think that I thought that was the question.
Was it? Maybe I misunderstood.
But it
So, very good question. Thank you for bringing this up. It's important to make distinction, like interaction with an object on the canvas or interaction in the model. So I deliberately stayed off the statistical side of it because, well, we can think of the interaction just another predictor, right? It's a combined predictor. So it just adds to the equation, and we just evaluate it as another predictor. So we can just keep building those terms as we go along and treat them as a sort of unique predictor, but it's really not. We know that it's a combination. So that's my response, right? We treat the statistical interaction as just another predictor and work it into the pipeline. There might be very well a way to represent the interaction graphically, but I suspect it's going to be a little more messier than this. So it might require some conditional logic or some graphical devices that treat that. I deliberately tried to be simplistic and reduce the complexity as little as possible so that people could focus on the workflow, on the going through the motions of reproducing those graphs, because in our experience, and Will can attest to that, it's hard to get people excited and sell them on this idea of reproducible workflow when you put too many cognitive strains, right? If you have to think about the model, you have to think about the data, you have to think about the code, you have to think about all that. So my approach was, as I'm trying to popularize the hands-on reproducible research, I want to minimize the work that people have to do on thinking about other stuff. And just do that. But I'm not dismissing the importance of what you said. Absolutely.
I do want to have another comment. I'm from a different tribe. So in my world, the workflow would, and what you described there in the second part would be different. So I'm a SAS user, and that's a total different universe and different approaches with things. And whatever you know the best, it's sort of what will you use?
Yes or no?
I'm not saying one is better than the other. It's not what I'm saying. It's just it would be different.
Well, maybe SAS is better than others for you, right? And R is better than others for me because I have exposure to that language and I can think more creatively in that language. I completely agree with you, and I think it's part of one of the most important issue for really promoting the practical side of data science because people are siloed depending on the language they used to. So that's yes, I agree with your point that whoever you go with whatever you're most comfortable with. However, I still think that there are objective differences in language that makes certain principles of programming easier to achieve than others. So for instance, in SAS, it's harder to achieve interconnectivity between separate processes and objects, right? So it's hard to pass data to model and a model to another model and that model to another graph. Whereas in R, because there is a greater glue between those things, it's easier to structure the whole workflow with less interruptions. SAS was my first language that I learned as a programmer, so it's very dear to my heart. But about 6 years ago, I realized that I'm limited, first of all, by the license, but secondly, by this flow, lack of glue that allows you to pass objects throughout the chain and not have to solve those problems of interconnectivity head on. But again, I want to defer to Will for a comment on this because
so you are not friend with the ODS.
Let's stick around. Let's chat.